Hi, this is Dr. Renzo Cataldo. I work with Biltmore Cardiology in Phoenix, Arizona. As we age, as we develop and acquire medical baggage, so to speak, over our lifetimes, our risk of atrial fibrillation goes up. As a matter of fact, at age 65 in the US population, approximately 4 to 5% of the US population will have a form or another of atrial fibrillation. The heart is very electrically active. There are 4 chambers to the heart, 2 on the top and 2 on the bottom. The bottom chambers of the heart are the main pumping chambers of the heart. The top chambers don't do very much pumping, but they give rhythm to the heart. So normally there's an electrical signal that originates here in the top right chamber of the heart, makes its way over to the top left chamber of the heart so that both chambers can be electrically activated and squeeze blood down below. Then that signal makes its way to the middle of the heart in an area called the AV node, which is kind of an electrical bridge between the top and the bottom chambers, and then the bottom chambers of the heart are electrically active. In the setting of atrial fibrillation, the top chambers of the heart are not in this nice normal rhythm that I just described, but the top chambers are basically in chaos. That chaotic rhythm translates into an inefficiency of the squeezing and pumping function of the top chambers of the heart. It winds up that the heart is not smooth on the inside, but we're born with these little pouches that stick out in the front of the heart. And these pouches are called the atrial appendages. Specifically, there's an appendage in the top left chamber of the heart where if one is in normal rhythm, blood is squeezed in and out of these appendages all the time. But if the top chambers of the heart are just kind of wiggling over here and not really squeezing blood very efficiently, blood can stick around and accumulate in these little pockets in the top left chamber, and one can have a blood clot forming over there in that top left chamber of the heart. And that's why a good number of people with atrial fibrillation need to be treated with blood thinners, right? Now, how else do we treat atrial fibrillation? Atrial fibrillation can be treated in one of several ways. We can shock it back into normal rhythm, but shocking back into normal rhythm is basically kind of like hitting the restart button on your computer. You'll still have the problem that was still going on with the computer, but you've solved the problem just temporarily. There are other ways to treat atrial fibrillation. One is with medications to try to keep you in normal rhythm. But the problem with these medications is that we have sort of like a significant respect for these medications because we know that a lot of them have a lot of side effects. Sometimes they're expensive. Sometimes they can accumulate in your body. A lot of times you just forget to take them. Sometimes they interact with some of the foods that you may eat or with other medications that you may take. Now, several studies have been done that try to look to see which is the best strategy for people with atrial fibrillation. And all of these studies have looked at patients just going down the medication route or going down the route of having a procedure done called an ablation. Almost all of these studies have overwhelmingly shown that ablation, even taken in the infancy of the disease itself, the outcome of the ablation procedure would be best. Studies have been done comparing medication options versus ablation, and ablations have consistently been shown to have better outcomes in the long term and in the short term compared to medications. What is an ablation? Specifically, an ablation would be a procedure to try to get rid of those areas that are responsible for atrial fibrillation. It winds up that the heart is very electrically active. If I took a friend's heart and brought him in here and took his heart out of his chest and chopped it up in lots of different little pieces, you'd notice, after they'd be mad at me, you'd notice that every little bit of the heart is capable of generating electrical activity, which makes the heart so fascinating. However, the blood vessels leading to and from the heart are not so sophisticated. They're like tubes, right? But we're not welded together like robots, right? We're in biological systems like you and I, there's always a transition zone between any two structures. Specifically, the top left chamber of the heart has 4 veins coming from the lungs, bringing oxygen-rich blood into the top left chamber of the heart. Now, the heart muscle itself and those veins kind of come together, but they have sort of a transition zone. So there's a transition zone between the heart muscle itself, which is electrically active, and the blood vessels leading to and from the heart, which are not electrically active. And that transition zone seems to be the culprit for most people's atrial fibrillation. Now, how do we get to that top left chamber of the heart? We can ask a surgeon colleague to open up the chest and work on directly on the inside of the heart. Or what we can do is to access the creases of the legs where there are veins, and we place some tubes inside the veins. Through those tubes, we thread some skinny little wires over to the inside of the heart. Now the veins, they kind of park themselves over here in the top right chamber of the heart, but the action is across the way. So what we do is we cross over from the top right to the top left chamber of the heart. There's a little membrane that separates the two top chambers of the heart. We pierce that membrane. We put tubes into the top left chamber of the heart, and through those tubes, we thread some wires that are very particular in the top left chamber of the heart. What we do is we create sort of a three-dimensional map, which is created with some computer systems. We figure out exactly where these veins are, and we create a shell of the top left chamber. And then what we would do is to proceed to electrically deactivate those areas that are responsible for atrial fibrillation. Now, for years now, we've been doing this ablation procedure, and we've either been deactivating those cells either by freezing or by burning. But the latest technology shows us that the best way to go, at least as of 2025, is something called PFA, which is Pulsed Field Ablation, where we apply electrical current in a very different way than the burning way, but it does not burn. It does not create a thermal injury, but we deactivate those cells that are responsible for the atrial fibrillation. And in general, what we do is we encircle these veins, electrically isolate them, and then different people can do different things, but we can isolate the backside of the top left chamber of the heart. That usually gets rid of the atrial fibrillation portion. And then what we generally do is we try to get people back into atrial fibrillation if they've been in normal rhythm throughout the procedure, and look for other areas that could be the source of atrial fibrillation. The procedure itself, I wish I could say that it's 100% successful. It's not. Given the right patient and given the right circumstances, we can expect about an 80 to 85% success rate with this type of ablation procedure for atrial fibrillation, which is good. It's very good, as a matter of fact, but it's not perfect. So we still expect people to be aware of their symptoms that they may have afterwards. If it's simply an atrial fibrillation ablation procedure without other arrhythmias that we're going after, should take an hour or less, perhaps a little bit more. The chances of anything at all going wrong during that procedure are very small. There's a small chance of groin complications over here at the puncture sites, usually in the form of just a bruise. Very occasionally, if it's something that's more than just a bruise and there's damage done to the blood vessels, I would have to call in a vascular surgeon to fix that. But that's about 1% of the time, so it really is not very much at all. Now, there could be a catastrophic consequences to these procedures, but they're quite infrequent. We're talking about less than 1% at all. Catastrophic consequences, meaning accidentally perforating the heart, causing a stroke or something like that. Those things can occur, but they're quite rare. After the procedure, we usually put a closure device at the veins so that you can expect to be up and around within an hour or two after the procedures. After that, we usually send people home. We expect people to have a little bit of discomfort within the first few days of the procedure. That's usually pretty benign and can be taken care of with Tylenol. We want you to continue taking your blood thinners and other medications thereafter. We'll probably give you a stomach protecting medication for about a month to prevent any damage that can be done to the food pipe during the procedure, which is quite rare. After the procedure, when should a person like myself be notified? If your atrial fibrillation is very significant thereafter, if it lasts more than an hour or so, we're certainly available for you. If you have a lot of pain, then it might be worthwhile to call an ambulance or present to an emergency department. The symptoms that are quite important for us is if you have significant shortness of breath, if you have significant amount of pain, if you have any neurologic symptoms, such as you can't move your face, you can't move your arms or legs, you can't speak in a coherent way, or if you lose consciousness. Atrial fibrillation can come and go. There's a lot of people who run marathons with atrial fibrillation and don't feel it, and other people wind up in the intensive care unit with atrial fibrillation. Everybody's a little bit different in terms of how they feel with atrial fibrillation. The main purpose And the main scope of doing this procedure can be to diminish your symptoms and decrease and completely abolish your symptoms. Beyond that, we can decrease the chances of your heart weakening as a result of the atrial fibrillation. We can decrease the frequent medications that you take on a regular basis. And actually, it's been shown that people can actually live longer, and also the chances of dementia can be diminished. This has become the most frequent ablation procedure that we do. It's quite common in Western society. Now, because the technology has gotten so much better, the studies have basically shown to go straight to an ablation in most patients with atrial fibrillation rather than trying with one or the other medication. So it becomes a procedure that we do multiple versions of this procedure almost on a daily basis. We're always very happy to treat patients the best way that we can, and we can treat your atrial fibrillation with improvement in your quality of care and hopefully get off all these medications. And we're very happy to be able to do this with Biltmore Cardiology.